So welcome to this conversation. We're going to have a panel discussion today here to talk about services that will allow you to stay in your own home because that's probably what most of you want. I know it's what I want. I know it's what my parents wanted. It doesn't always work, but with some help, a lot of times it can. So we've got three experts here today. And what I'm going to do is just go around the room and ask each one of them to briefly tell us who you are, what the name of your company is, and what kind of services your company provides. Okay. And then we will get into a few other questions. So we're going to start with who is at my top, which is Angela Davis.
Yes. Hi. Thank you for having me. First of all, Care Partners, you're doing a great job. I tell you, I've been having a lot of fun this morning. So thank you so much. But my name is Angela Davis. As I said, I'm a social worker and a client care manager with Home Care Assistance, and we provide personal assistance services. I'm the person that you will see along with two other client care managers. We come out and we provide assessments and matching of caregivers to come into the home. Definitely, as we go through, you'll hear more, but we're definitely believe in matching, putting the right person in place. And also we focus a lot on brain health as well that we've talked about. And we have a program, our cognitive therapeutics program, which helps with, it's a holistic program for brain health and for the clients. So thank you for having me this morning.
Great, great. Thank you for being here. Lanita, talk to us about you and your company and your services, please.
Hello, thank you for having me as well. It's been a joy to be here. Great information is being shared for us and the community. I am a social worker. I work with ATC Home Health. Our home health company is located in Porter, Texas, and also in Conroe, Texas. We focus on keeping the patient at home. We provide home health care in the home. There's different disciplines that go out to see the patient and treat the patient in their home. One is skilled nursing services, physical therapy services, speech therapy, social work services, and home health aides.
Okay, great. Thank you so much. And last but not least, I'd like to bring Kathy Zaleski on. And if Kathy, if you will just tell us a little bit about yourself and your company.
Hi there. My name's Kathy Zaleski. I've actually been in hospice since 1992. That is so long. Oh my goodness, it's crazy. I know. So I've seen changes, from back then to now, and I think the biggest thing that I see that is so different now is there's so many more providers that understand, what can be done, and the biggest thing is that hospice is not only for the very last end. You know what I mean? It's the biggest misconception is people think that we're only going to be necessary and needed when a patient has, a week left to live. So about my company, AMED is one of the largest, if not the largest, hospice organization in the Houston area. And one of the unique things about our company is that we're a family-owned business. So our owners down in Texas City, we have 3 different offices, one that covers the north area, which I'm part of, the west, and then Texas City. So we provide, end of life care that specializes in just keeping patients comfortable and have the best quality of life as possible during the last time that they have. So my role is to educate those providers out in the community and educating them about what to look for, what makes a patient appropriate, and to come in and explain our services to the patient and the family and help get that patient admitted basically to our service.
Okay, great. And I just want to point out, my mother was on hospice for almost a year and a half. We could not have done it without the hospice team. So I've used every service on this panel right now. All of them: home health care, home care, hospice, every one of these services has a value, and it depends on where your situation is at the time, which one you need, but they all have value for you. I want to point out there's 2 services on this panel that are paid for by Medicare. And so you want to make sure you get all that you can from Medicare, right?
Mhm.
Okay, yeah. Everything we can get out of Medicare, we want to get. So we're going to talk about that. First, I want to clear up something, because I think a lot of people, I know I did when I first started helping to care for my mom, we were very confused about the difference between home care that Angela's company provides and home health care that Lanita's company provides. So who would like to speak on that?
Lanita, would you like to?
Okay, I'll go first. With home health care, if someone needs home health care, they have to be referred for home health care by their physician. The physician normally writes the order for home health care. And by chance, if you're at your doctor's office and you think you need home health care, then you can also ask the doctor for home health care, but you have to have a skilled need for the service. And so the skilled need for the service would be a new diagnosis. You may need medication management plus monitoring the medication. You may require wound care. Different situations like a colostomy bag, just situations like that. There has to be a skilled need for home health care to actually be in your home due to Medicare requirements.
So when you think of home health care, think medical, okay? Do I have a medical need? You're going to get a nurse, you're going to get other team members that can help. I'll give you a couple of, for instances. We used home health care to help my mother-in-law with wounds. As she got older, her skin was very, very thin. I used to say you could just almost look at her and her skin would tear. You know, that's how thin her skin was. And so we had to have home health care in regularly to dress those wounds and make sure that they didn't get infected and that sort of thing. Very, very important. My dad had a stroke. Home health care was brought in to help after the stroke. My mother had arthritis. Home health care was brought in to do therapy. So speech therapy, occupational therapy, all of the physical therapy, all of that can be done in your home through home health care. And you can ask your doctor for it. A lot of times doctors don't automatically think to suggest some of these services, and you can ask them to refer you for home health care, just like, and we'll talk about this later, you can also ask them to refer you for hospice care. So you understand that you have the right to ask, and let your doctor know what you need. He's not a mind reader, and he or she is very busy a lot of times, and they just don't think about these things.
And Catherine, may I add with, there's like 2 other issues too with diabetic care. If someone is just recently received the new diagnosis of diabetes, so we have to go out to educate them on how to manage that and to monitor it. And with the medication, sometimes the medication may not work, and sometimes the medication may have to be switched. Do they need pill form at this time, or injections required? Sometimes injections are required. And with home health, we monitor pain management as well.
Now, Lanita, a lot of times your company works in tandem with a company like Angela's, correct?
Absolutely.
Yeah.
Absolutely.
Yeah,
So thank you.
And so Angela, tell us a little bit about that and what your company does and how it differs from what Lanita's home health care does.
Absolutely. Thank you very much. So we're a personal assistance service that comes in and works in conjunction with home health and hospice. So we can stay in place at all times. A referral is not needed for our services. Many times, for example, families, they might have home health in, but they need some additional care in terms of the caregivers coming out. And that's when we come out and we assess to find out what the need is. A lot of times when a person is even coming from the hospital as a client care manager, and that's what really makes us unique. We have client care managers that will come out and provide an assessment. And so when we go out and provide the assessment, sometimes we're actually referring to home health or to hospice companies because that's needed. So we're all working together. We are licensed by the state, so we follow strict protocols, and our caregivers can provide assistance with ADLs, showering, bathing, meal preparation. They can take to doctor's appointments. Also, we don't just provide the activities of daily living, but we have we focus on brain health. And that's important too, because we want to make sure that the client is physically and not only physically stimulated, but mentally stimulated as well. So that's how we provide. When we're in, when I'm in, I'm assessing everything to see how a person is doing so that I can make that proper referral to our care partners. So yes. And we are, in terms of the payment, let me not forget about that, the difference as well with the two programs, of course, covered by Medicare. And I do agree with Kathy on that, you know, what you can benefit from there, definitely. But we are private pay. And also, if you have a long-term care insurance policy, we will assist with you getting reimbursed through the long-term care insurance policy, as well as if you're a veteran, aid and attendance services will assist with that as well, helping get reimbursed there. So
yes, and we're going to be talking about that more in another session today, how to pay for this care. So yeah, thank you for that. So I want to move on down to Kathy for a few minutes. We touched briefly about hospice and how it's not just for the last minute. A lot of people wait way too long to get hospice care on. And I'm telling you, it was the best thing my family ever did, was to bring that hospice. It's a scary word. I get it. You know, a lot of us hear that word and we just think, oh gosh, this is the end, you know, and it's not necessarily. Like I said, my mother was on it for almost a year and a half. My mother-in-law was on it for 7 months. The services that they provide are second to none. So Kathy, talk to us about a hospice team and how that works.
Well, the way that the Medicare hospice benefit is set up is we're to work with an interdisciplinary team. And I always tell patients and families that they are the leader of the team. We're not going to come in here and do anything that you don't want us to do. I mean, you are the leader of the team. We have below that, so to speak, we have an RN case manager that is going to kind of manage, you know, the services that they receive. And for our company, we will have an RN case manager that will see a patient minimum twice a week. Now, the Medicare guidelines require that a hospice RN see a patient once every 2 weeks. That is too much time in between, we think, you know. So we now, again, there are some patients and families that we don't want you here twice a week, you know, but we want to have that, you know, knowledge of what's going on. So what that RN case manager is going to do, they're going to go in, and every time they're there, they're going to do a complete assessment. Is there anything that looks different today from last time I saw you, your symptoms, your pain management, anything like that? And they would be the eyes and ears of the doctor. They would call that physician, who's the attending physician, who's also a member of the team. And if we need to make any changes for medications or anything like that, you know. So people ask me all the time, well, you know, how long does she stay? Well, I have time to go and get my hair done or whatever. No, I mean, because there's not a certain time like what you do, Angela. You know, you are set by, you know, maybe 4 hours, or okay, you're gonna have somebody there for 4 hours. Well, our team goes in, and however long it takes for that nurse to do what she does is how long she'll be there. I had a nurse call me yesterday about a new admission. And she said, Kathy, I was there for 2.5 hours. And it was not that she was providing direct hands-on care, but she was educating. She was going through their medication list. I mean, the family was just a mess. You know, they just were nervous and not quite ready for this. But then when they realized that it's not like we're speeding anything up, you know, we're there to support them. But then other times the nurse may go in and only spend 30, 45 minutes. You know, it's depending on what they're doing. The other, really, I hate to say, but the member of the team that the families tend to really rely on the most is the certified nurse's aide. We can provide a nurse's aide in the home anywhere from 3 to 5 times a week, and that's Monday through Friday. So again, they go in, provide all the personal care. If the patient has a hospital bed, they can change the linens on the bed, give them a bed bath, wash their hair, oral care, you know, everything. So, and again, that could be 45 minutes, that could be an hour and a half, you know, depending on how long it takes for that particular patient. And the way that we handle the supplies, it's our nurse's aide that would bring in the diapers and the chucks and all that, you know, the gloves, etc. So
that's a huge benefit.
Mhm.
Oh
yeah,
my
yeah,
gosh. When my
because you're
mother
paying
went
for that
on it,
yourself typically.
yes, yes. And it's very expensive. Any of those of you who have had to buy incontinence supplies for someone, it's quite expensive. So
Mhm.
that was a big benefit when we got on hospice. We didn't have to buy all that anymore.
Yes,
They
exactly.
provided that, and that was great. Thank you.
Our team also includes a chaplain and a social worker. And I tell my families I meet with that they're going to call you and introduce themselves and can we come visit? And you say yes or no. Take advantage of as much or little of that as you'd like, you know. So and that just depends on what the family wants. And then we've got a team of volunteers, which honestly right now during the pandemic, you know, we don't have as many volunteers as we always have. But that's, you know, that's the way it is right now. And then also bereavement. We do follow those patients, not the patients, but the families for at least a year after the patient passes away.
Oh, great services. And let me tell you, like I said, we couldn't have done it without them. But you are probably going to have to pair that possibly with somebody like Angela's service, the home care assistants. You're going to need a home care company in there for those extended periods of time when maybe you cannot be there, or maybe you just need to get some sleep. Maybe your loved one is up all night and you can't sleep and you need somebody to come in so that you can get a good night's sleep so that you can be at your best. Another thing I want to talk about, ladies, is falls are a huge concern for many seniors. And for those of you, the two ladies in home care and home health care, let's talk about how your services can help prevent a fall. Now, we can't stop all falls from happening.
No.
There's no magic bullet, but there are things that can be done to help prevent that. So I'll start with Angela and then we'll go to Lanita.
Absolutely, Kathy. No, you cannot stop all falls. However, that is a part of our assessment when we go into the home. I'm looking at tripping hazards. I'm looking at the bathroom. I'm looking at what's going on in the room. I'm looking at everything when I'm going into the home. Our caregivers are there. Sometimes people's endurance is, you know, they're becoming weaker, and a lot of when our caregivers are going in, they are doing slight exercises, you know, with them. When you're returning from the hospital or even a rehab, and even if you're continuing on home health, we can actually, if they leave home exercises, we can assist with that and all of that strengthening, and it helps to prevent those falls. We're constantly monitoring, we're constantly watching. And remember, a lot of times too, you will find that when people, sometimes they might drink enough and things like that, they're becoming dehydrated, and, you know, sometimes with medications. And so we're watching all of that to ensure that there isn't a fall. Yes, can a fall happen when we're there? Most definitely. But we're there to prevent those type of things, to actually look at those changes that are going on so that we can prevent those type of things. And our caregivers are certified nurse aides as well as professional providers. They're more more than well trained to monitor those things, and then they report back. And when I provide my monthly visit or as needed visit, then I'm going in and I'm looking at changes and some modifications that need to be made, so that I can call the care partners and say, hey, you might need this DME. Hey, maybe you need this, or maybe you need it. Maybe look at an order for your doctor to get some home health, or maybe some outpatient therapy or something, and this and that. So that's how we can help with preventing falls at home.
Great, great. Yeah, I always say all of these companies, they're an extra set of eyes on
Yes.
somebody that you care about. And it's always helpful because they're also outside eyes. So they're going to see things that maybe I missed because I'm too close to the situation and I didn't notice that or whatever. But so it's always good to have those extra sets of eyes on the person that you're caring about. Lanita, tell us about home health care and how that can help people who are fall prone with your services.
Okay, with home health, usually the physical therapist works with the patient on fall prevention. If they've already sustained a fall or two, then they work on muscle strengthening and how to prevent those falls. They talk to them about transfers, how to properly transfer from their chair to the wheelchair, or how to even, stand up safely. And eventually, sometimes patients refuse to use those adaptive aids, the cane. Sometimes as a social worker, when I go out, the cane is in the corner or the walker's like way over there. So those items, I remind the patient, use your cane for balancing. If you have to use a walker, it's okay. We don't want to experience another fall again, because sometimes one fall could result in a hip fracture, and sometimes it could just be just a minor fall that you could take some Tylenol and use a heating pad, and then you're okay. But sometimes they require hospitalization. And in the event if the fall is questionable, you contact the home health care agency, talk to the nurse. We have mobile x-ray services that can go out to do an x-ray in the home, opposed to going to the hospital. But by all means, if someone is truly hurt and in severe pain, then seek professional help at the hospital.
Okay, so I'm going to ask you this question, and then I'm going to ask it also to Kathy. How would I know if someone is more appropriate for home health care or hospice care?
If they've been with,
Go ahead.
Start with Lanita, and then we'll go to you,
Oh,
Kathy.
I'm so sorry. Go ahead.
Okay. If they are on our service with home health care, usually they've been on our service for maybe, a few months or 6 months, or maybe just for a long period of time. And we may have watched them, their health be managed, but then their health is also deteriorating. At that time, sometimes the doctor will write an order for hospice care. Sometimes we identify that, and as a social worker, I have to have that conversation with the family members. If I see things, kind of going that route, I want to start having a conversation just so they can, it can be put on their mind that this is something that you may have to think about. We love all of our patients. We want to continue to care for them as long as possible, but sometimes, hospice is warranted.
Okay, Kathy.
I get in this conversation a lot because I have patients that are on home health and then they've been referred to hospice, and helping them to understand the difference and why, and correct me if I'm wrong, Lanita, when I describe the home health part that I say, but when a patient's on home health, we have a goal, and the goal may be to be able to have that physical therapist in, and you're able to walk across the room or to the bathroom, or get your wound is healed, or, you have a goal in mind, and that is documented and is, approved by the insurance and all that. So, and typically you would start out with a lot of visits, more visits in the beginning, and that may taper off. with home health, because as you get closer to that goal, you need fewer visits. Am I accurate with that?
You are correct.
Somewhat. Okay. So with hospice, it's the opposite. So someone may come on our service now, let's say a cancer patient, for example. A cancer patient can have terminal cancer with a prognosis of 6 months or less, and they are still teaching a Sunday school class. You know what I mean? You're not going to be able to see it like you could see like a heart failure patient or something, but they're still appropriate. So let's say they would, maybe have that nurse visit once a week or once every 2 weeks, and maybe they don't even want a home health aide yet at all. So it's very, very little. But then as things progress, they could end up with a home health aide 5 days a week, a nurse visit minimum twice a week. And then if they start having pain or symptoms that can't be managed with those intermittent visits, then they may even qualify for that other level of care called crisis care. So, and that is for a very short-term time, whatever that patient is in for a crisis, uncontrollable pain, nausea and vomiting, shortness of breath, something like that. We want to get them out of that crisis and get them back to just regular, the way it was before. So that's really the difference, in a sense that we know what the ultimate is going to happen with our patients, and with home health, we know those folks have a goal. They're going to get better. The goal is to get, everybody wants to get better, but you have a goal in mind. Well, we know that our patients aren't going to get better. And as time continues, we're going to increase more visits. So that's, kind of how, in my opinion, how I explain it, when somebody's wondering, is it hospice appropriate or home health? And one big thing, you cannot have both at the same time.
Good point. Good point.
Yes.
Okay, ladies, unfortunately, I can't go through all of the questions I had for you, but I know our attendees here would like to ask their questions. So we're going to get it ready and go ahead and turn it over into breakout rooms. Darren, are you ready for that? Okay, so we're going to break out into 2 rooms. One, we'll have Kathy Zaleski in the room talking about hospice. So if you have hospice specific questions you want to ask Kathy, join that room. In the other room, we will have both Angela Davis with home care assistance and Lanita Nickerson will be joining for home health care. So we'll have home care and home health. So if you have some questions about those 2 services, that's the room you want to go into. All right.